Right, let's jump straight into this explainer and decode the critical, evidence-based updates from the latest RCOG Green-top Guideline on recurrent miscarriage. If you're prepping for your MRCOG exams or, just looking to update your clinical practice, you are in exactly the right place. We're going to break down Guideline number 17 into a structured, highly digestible format that'll actually make these recommendations stick.
So here's our roadmap for today. We'll be looking at defining recurrent miscarriage, epidemiology and risk factors, recommended clinical investigations, evidence-based treatment options, and finally, supportive care in practice. Let's get right to it.
Section 1. Defining recurrent miscarriage.
Okay, so the crucial takeaway here is that while the strict textbook epidemiological definition remains 3 or more first trimester losses, the actual clinical guideline has evolved. You now have the clinical green light to initiate a full evaluation after just 2 losses, if, of course, there's a suspicion that they're pathological rather than merely sporadic. For instance, if a patient had a pregnancy loss with a completely normal karyotype, you wouldn't just sit around and wait for a 3rd loss to start investigating.
This quote right here brilliantly captures the whole call for reform from the Lancet series, which the RCOG guideline echoes. It's really about bridging that gap between sporadic and recurrent miscarriage care. We're moving towards a systematic, graded approach, evaluating health needs after 1 loss, offering specialized clinic support after a 2nd, and then pulling the trigger on full, evidence-based investigations after 3.
Moving on to Section 2, Epidemiology and Risk Factors.
For your MRCOG exams, you literally have to be able to rapid-fire these modifiable lifestyle factors. You'll counsel your patients to maintain a BMI between 19 and 25, completely stop smoking, and limit alcohol. Now, these are grade D recommendations based on observational data. But, and pay close attention here, limiting caffeine to less than 200 milligrams a day carries a stronger grade B recommendation. Don't let that little distinction trip you up on test day.
All right, Section 3. Recommended clinical investigations.
Now, I love this part because it's some real myth-busting. You absolutely must always offer screening for acquired thrombophilias, specifically lupus anticoagulant and anticardiolipin antibodies prior to pregnancy. But on the flip side, routine screening for inherited thrombophilias like protein C deficiency or the MTHFR mutation, just don't do it. It's not recommended. The data shows they only have a super weak association with recurrent miscarriage.
Here's another highly testable comparison. Examiners absolutely love to catch you out on this one. You definitely should assess for congenital uterine anomalies, and the gold standard here is a 3D ultrasound. That is a rock-solid grade B recommendation. However, routine immunological screening like natural killer cells and torch infection screening, those are almost always incorrect choices on your MCQs. The guideline explicitly points out that organisms like toxoplasmosis and rubella just do not persist in the genital tract in a way that causes recurrent losses.
And when it comes to genetics, look, blanket parental karyotyping is completely outdated. The abnormality yield is literally less than 2%. Instead, you've got to follow the strict 2-step evidence-based pathway. Step 1 offers cytogenetic analysis on the pregnancy tissue itself for the 3rd and subsequent miscarriages or for any 2nd trimester loss. Step 2, you only offer parental peripheral blood karyotyping if that pregnancy tissue actually reports an unbalanced structural chromosomal abnormality.
I want you to take a mental screenshot of this summary right now. It's pulled straight from the source material. Cementing these exact evidence grades is totally non-negotiable for passing your MRCOG. Notice how clearly it maps out exactly what we just discussed regarding thrombophilias, ultrasounds, and genetics.
Next up, Section 4. Evidence-based treatment options.
This breakdown is absolute exam gold. For women diagnosed with antiphospholipid syndrome, or APS, you're going to offer aspirin and heparin from a positive pregnancy test until at least 34 weeks of gestation. And if a patient with a history of recurrent miscarriage presents with bleeding in early pregnancy, well, you should consider 400 milligrams of micronized vaginal progesterone twice daily until 16 weeks. Both of these are solid grade B recommendations, but check out the highly testable grade A recommendation at the bottom. Do not routinely prescribe thyroxine supplementation to euthyroid women simply because they happen to have thyroid peroxidase or TPO antibodies.
And finally, Section 5, Supportive Care in Practice.
75%. Think about that number for a second. It is a powerfully reassuring clinical fact for both the ward and your exam. Couples with unexplained recurrent miscarriage have roughly a 75% prognosis for a successful future pregnancy with supportive care alone. Offering that supportive care, ideally in a dedicated recurrent miscarriage clinic where they can see the exact same doctor, get early scans, and actually feel heard, is a formal Grade C recommendation.
So, as you finalize your exam prep, consider the real-world power of these strict do's and don'ts. They don't just guarantee you marks on the MRCOG, they actively protect your patients from unnecessary, costly, and anxiety-inducing tests. You've got the evidence-based framework now. The real question is, how will you integrate this shift from fragmented care to a systematic, evidence-based clinical pathway to transform your daily practice? Keep this explainer handy as a quick visual review, and best of luck with your continued learning.